then you have metamyelocytes, you have bare forms, and you have the neutrophils. Okay, so by definition, usually for acute leukemia, we say that you need to have 20% blasts at least. Okay, say a leukemia is an acute leukemia, you need to have about 20% blasts, either in the peripheral blood or in the bone marrow. Right. This leukemia, acute promyelocytic leukemia, you don't need to fulfill that specific criteria, right? Because you can have promyelocytes, and if you look at the maturation of granulocytes, you have a lot of granules in these granulocytes, right? And these promyelocytes have a lot of granules, right? So because of the release of these granules, you can get different set of complications. I'm not going to go into that. I'm just giving you sort of an overview. Okay, like DICs and various things. So let's leave that aside. But technically speaking, acute leukemias, you will have at least 20% blasts in most cases. Okay, so hyperleukocytosis you can get when you have a large number of blasts, usually over 100,000. Right. So the chronic ones, you can have chronic myeloid ones. Okay. Again, if you have very high counts, like the classical one would be CML or chronic myeloid leukemia, right? So recently I had a patient with a chronic myeloid leukemia whose white cell count was 300,000, right? If you look at the lymphoid ones, okay, chronic lymphocytic leukemia is sort of the counterpart of the lymphoid counterpart of the chronic myeloid leukemia. The chronic lymphocytic leukemia usually does not cause hyperviscosity, right? Because those cells are very small, right? And therefore they don't really cause. So you might have someone coming to you with a white cell count of 300,000, but if it's a CLL or a chronic lymphocytic leukemia, you may not have the hyperleukocytosis or the hyperviscosity you get, which you will have with the chronic myeloid leukemia. Okay, so these are just things to keep in your mind, out there, right? So hyperleukocytosis, then of course tumor lysis, right? You all sort of come across tumor lysis. This can be the initial presentation, right? So someone has a very high white cell count, they can come with tumor lysis, a syndrome, tumor lysis or tumor lysis, or else they can come post-treatment. So they come in, they go somewhere, get some treatment, and due to the cell breakdown, they can come with tumor lysis. Okay, so that's the second one. Then hypercalcemia. Hypercalcemia, anyone knows in hematological malignancies, any malignancy you can have hypercalcemia, but anything that comes to your mind. Multiple, excellent, yeah. So multiple myeloma can come with hypercalcemia, and then there are some other lymphoid malignancies called, you don't have to worry about it too much in Sri Lanka because ATLL or acute, sorry, not ATLL, yeah, T lymphocytic leukemias don't really come, so no, not acute, adult, right? ATLL, adult T lymphocytic leukemias don't really, we don't have many of them in Sri Lanka, right? They are more common in the Afro-Caribbeans and in the Chinese and all that, right? So you don't have to worry too much, but that does classically, ATLL can classically present with hypercalcemia. Okay, right? So hypercalcemia, then of course cord compression, right? Again, patients can present to you with cord compression. What any examples? Sorry, any hematological malignancies which can notoriously present with cord compression? Multiple myeloma, right? And any of the other malignancies also which can obviously form what we call the chloromas or myeloid sarcomas, where you can get local collections of malignant tumor cells. Okay, right. Then I told you about the acute promyelocytic leukemia. We'll keep it for another time. Then chemotherapy-associated thrombosis and asparaginase, which we give for lymphoblastic leukemia, ALL, right, can result in thrombosis. Okay, so patients can present to you with thrombosis, like maybe cerebral venous thrombosis or any other types of thrombosis, because these can lead to one of the conditions is called antithrombin deficiency. Right? You know about antithrombin 3? Okay, so asparaginase can give rise to antithrombin deficiency. Then, of course, leukemic meningitis, so deposits, meningeal deposits or CNS deposits of any hematological malignancy. It can be acute or it can be chronic, right? And then neutropenic enterocolitis, and so on. But basically speaking, this is just a list of some of the things which you might come across in your emergency emergency, when you're in an emergency, or you're going to be working, I think, in a sort of an ETU setup, right? Yeah, where you'll be the first contact. Is that right? That's what I was meant to understand. Okay, right. So we'll, after Prasanna, maybe if we have time another time, we'll sort of discuss some of this in brief. But I think my mandate is basically to talk about neutropenic sepsis today in a little more detail. So when we look at neutropenic sepsis in hematological malignancies and hematological conditions, this is like sort of very, very common, right? It's part of sort of our bread and butter to see patients with neutropenic sepsis, or to see patients with neutropenia. Okay, and some of them can get obviously sepsis. Now, especially we know that can occur due to malignancies, per se. You can get chemotherapy or drug-induced neutropenia, and of course, we are now doing stem cell transplant and all that in Sri Lanka. So you have more causes or more patients with neutropenia, right? So drug-induced primary malignancy, and of course, in the post-transplant setting, all these things can give rise to neutropenia. And there are various series which give you various data, and in these transplant recipients, up to about 60%, right, can develop bacteremia associated with a significant mortality. Okay, right. So if you look at incidence of febrile neutropenia in high-risk situations, it's very common during transplant, right? And if you are unfamiliar with process of bone marrow transplant or stem cell transplant, basically very, very briefly, what you would do is someone has some sort of a disease of the hematolymphoid system, right? So what you do at the transplant, you give very high doses of chemotherapy to destroy the bone marrow, right? And then you would either put back his own stem cells or stem cells from a donor, and they would go and they have what is called the homing device. They can find their way. Stem cells can find their way into the donor recipient's bone marrow, go in there, sit there, and start then producing their own cells, right? So that's very basically what stem cell transplant is. And during this period where you have ablated their marrow or given very large dose of chemotherapy, they are usually neutropenic or have a neutrophil count of 0 or maybe 10-14 days or longer if necessary. Okay, and thereafter, the rest of the immune mechanisms are also all not working properly, because we give immunosuppression to take out the lymphocytes as well, the T cells, right? Because we want to prevent things like graft rejection and things. So you can have patients who are immunosuppressed due to the fact that their lymphoid cells are also taken out, which is the T cells. Okay, right. So patients who have undergone transplant obviously have a high risk of getting febrile neutropenia. And if you take AML, or acute myeloid leukemia, about 40% of patients at diagnosis can be having febrile neutropenia, right? Okay, are you clear? In the AL group, it's a little probably less than that, but these can occur during chemotherapy, right? Then, if you look at the febrile neutropenia related mortality, in autologous transplants, you can have up to about 10% mortality. In allogeneic, so autologous means you put their own cells. Allogenic is obviously from a donor. It can be very variable. Then if the graft fails, so remember we have destroyed this patient's bone marrow, we have put in stem cells from someone else, and the stem cells haven't taken up. So the graft has failed. So what do you think this patient now has? We have destroyed the bone marrow. The stem cells that we have put in have been rejected, so they are completely devoid of any immune system, right? Now they can have a very, very high risk of febrile neutropenia and death due to neutropenia, right? So you have to be careful about situations like this coming in to the ETU, okay? And then, of course, these are just stats during the first 2 months in AML and then induction of ALL. So remember, the acute leukemias and the chemotherapy given for acute leukemias can result in a significant neutropenia. And remember, we have knocked out the other parts of the immune system also, so therefore they are very, very susceptible to getting infections, right? Okay, so if you look at the incidence of sepsis, in the general population, if you say severe sepsis is seen about 0.5 per thousand. Hematological malignancies, it goes up to about 66 per thousand, so about 6%. If you take AML patients specifically, in AML patients, they are much higher, right? 275 per thousand population per year. And one of the important things that you will have to remember is that these patients, might not have fever. Okay, so because of the abnormal immune response, we have knocked out their immune response. So therefore, they might be having very, very high levels of bacteremia or sepsis without any manifestations of fever. And that's something which is very important to remember. So you need to look at this general condition, right, of the patient. Is the patient looking ill? Is they sort of sweating? Restless? Maybe a little bit of bleeding due to thrombocytopenia and all that sort of thing. Okay, so the general appearance and the outlook of the what you see of the patient will be quite important in this group of patients because we have knocked out the immune system, the natural immune response. Right. So, what do you know about gram-negative sepsis in a neutropenic patient? Let's say you have a patient with a neutrophil count of 0.1 or 0.2, and if they develop a gram-negative sepsis, like say Pseudomonas E. coli Klebsiella, then what do you think the outcome of this patient can be? Patient can be dead in hours, right? But you don't need to. The patient doesn't need to wait till tomorrow morning to die. They can be dead in very short period of time. So therefore, it's very, very important for us to identify these patients very, very early, right? Even before you actually have a blood count, it's important for us to be able to detect that this patient is having sepsis, right? Otherwise, by the time the blood count comes, you probably be resuscitating the patient in terms of cardiovascular resuscitation, right? Cardiovascular resuscitation. So that's one thing that you need to bear in mind in your history. Is the patient having a hematological malignancy? Has the patient been on recent chemotherapy or on any immunosuppression, right? Okay, because there is a significant mortality associated with this group of patients. Okay, so now when you look at there's a clear relationship between the severity of neutropenia and the intensity of chemotherapy, right? We know that. There are some chemotherapy protocols which are more neutropenic than others. So generally, you can classify these as high risk, intermediate risk, or low risk of developing febrile neutropenia, right? So again, if a patient presents to you in the ETU, you need to find out or try to find out what sort of chemotherapy this patient has had, right? And you need to have a rough idea of that. It doesn't really serve a lot of purpose to say, okay, patient is having a leukemia and patient has been on chemotherapy. It's important for us to realize or know a little more than that to see what sort of chemotherapy the patient has had. So basically, if you have very high risk, there is more than 20% chance of having a febrile neutropenia, then we say that this is a high risk protocol. Likewise, 10 to 20 intermediate and less than 10 low risk protocols. Right. Now, why is that important for us? Oh, sorry. In addition to this, in addition to the type of chemotherapy, right, that these patients have been given, and the type of disease that the patient has, there are other risk factors which could increase the risk of febrile neutropenia. Obviously, age, right? Older patients versus younger patients. Advanced disease. So you'll have to find out, okay, was this a recent diagnosis? What is the stage of the malignancy? Is it a stage 4 lymphoma? Is it a stage 1 lymphoma, right? Then history of prior febrile neutropenic episodes, right? Very, very important. So if it's a patient with, say, a high-grade lymphoma, and the patient has come with some fever and neutropenia, you need to find out, okay, if the patient has had 2 or 3 cycles of chemotherapy previously, have there been any episodes of neutropenic sepsis? Have there been any ITU admissions, any hospital admissions, right? Because this time round, things might be worse than the previous time, right? So in your history, you need to come up with those things, right? Is the patient on antibiotic prophylaxis, and is the patient on GCSF, right? Colony-stimulating factors. Because usually some of the protocols we don't give prophylactic GCSF, chronic stimulating factors. We'll look at it later. Some patients we don't give prophylactic antibiotics. Okay, so you need to find out from the patient whether the patient is on any prophylaxis or on any chronic stimulating factors. In mucositis, right? Have you ever seen patients with mucositis? Post chemotherapy or post transplant mucositis, right? Now, like you get sort of mouth ulcers, very raw surfaces, which are very prone to get infections, right? Now, if a patient has mucositis, then there's a higher risk of developing infection, because you know that mouth is probably one of the dirtiest places in our body, right? So there are a lot of organisms which can go in there, and therefore we usually recommend very good mouth hygiene in patients with neutropenia. Okay, either during chemotherapy or in the recovery phase, or even during when they're diagnosed. Before you start chemotherapy, if they're neutropenic, we tell them to use mouthwashes like chlorhexidine mouthwashes, right? After every meal. Then sometimes we use antifungal paste, right? Antifungal creams like Dactarin, amphotericin lozenges, nystatin, right? Various things to try to keep the mouth clean. Okay, very important in neutropenia. Then the performance status of the patient. Obviously, we'll be assessing the performance status, and then if the patient has cardiovascular disease, right? Obviously, if a patient has some sort of a cardiac compromise, they will be more susceptible to mortality with sepsis. Okay, so these are some of the factors which increase the risk of febrile neutropenia, and you need to be aware of how you assess these patients when you come into their first contact. All right. Now, obviously, if you can grow something from these patients, say blood or wherever, then their prognosis is sometimes a little worse, because what we think is that then the amount of organisms or the amount of bacteremia, the load would be higher than if you can't grow, right? Because then we can identify the organism, the sensitivity of the antibiotics, and be more targeted, right? And we all know that usually in these patients with neutropenic sepsis, only about 20% are blood culture positive, right? A lot of the times they have very high fever, they are maybe even hypotensive, they've been very ill. But when we send off blood cultures, we really can't isolate an organism, right? So roughly about 20% of blood cultures come back as positive, right? Right. Then also the other important thing is another very important thing when you're seeing this patient and examining them is if there's a focal site of infection, right? So what are the sort of focal sites that you would look for in a patient who has high fever? Maybe the patient has come to you, a patient who has had chemotherapy a few weeks back. They come to you with very high fever, feeling quite unwell for about 24 to 48 hours. When you ask them whether they have a cough, no cough, right? No urinary symptoms. What are these places where you might have some focal corrections? Sorry? Chest, yeah, okay. Chest, but chest is something where you might have some symptoms. You might be able to listen to the chest and find out some symptoms. So chest is very important. But I'm talking about some areas where you might not, routine general examination, pick up some things. Skin, yes. So skin is something which we have to examine very carefully, right? Remember, patient, if the patient has enough neutrophils, you might have like painful abscesses. Okay. Now here's what is an abscess? Abscess is a collection of pus. Pus is what is pus? A neutrophils, right? So in a patient who has no neutrophils, how do you get a collection of pus, right? So you may not have these, large painful abscesses scattering between the face. Mouth, right? You can have like dental abscesses. Okay, all these things you have to be very careful to look at to try to elicit out your collections of pus and so on. Okay, right. Ah, right, fine. Okay, so that's something which you need to find out because obviously, then if there is, you can address that very quickly. Is it not changing? How do I scroll up or how? Okay.
Just get it delayed so then we
Yeah,
can.
that's okay. So can I? Right. So I'll just take you through. Let me just take you through some like a patient, right? A patient of mine whom we sort of go through and see uh, what happened and so on.
Just bring
Right. Okay, right, fine. Okay, so this is was a 55-year-old man, and he was diagnosed with multiple myeloma some years back. He had a lot of skeletal disease. He was given chemotherapy, right? So cyclophosphamide, bortezomib, dexamethasone, and he went into a remission, right? And he was actually playing golf, and he was very well. Okay. Oops. All right. Then he had a because of the myeloma. Once the treatment of myeloma is in a patient who's fit and well, we give them chemotherapy, and once we get them into a good disease response, we try to consolidate them with a autologous stem cell transplant. Right. So you give them, we sort of harvest their cells, the stem cells, give them a high dose of melphalan, and then you put back the stem cells. Okay. Now this is not a cure. You cannot cure myeloma as it is of 2018, but this will delay the relapse or the resurgence of myeloma, and that is what the recommendation is now internationally. If the patient is fit and well, that they should undergo autologous stem cell transplant. So he had a transplant, and then anyway he relapsed 2 years after that. He was given more chemotherapy, right? So now this guy has been having chemotherapy for quite a few years, but he's doing well, right? In the sense, when he's doing well, he's going to work, he's playing golf, and so on. Right. Then, about 3 months into a new chemotherapy, he comes with feeling very tired and pain in the jaw. Okay. What do you see in this? Yeah. So, right side of the man, or right jaw, right mandible, you see like a big sort of a cystic lesion. What do you think that is? In a patient with myeloma, abscess is a possibility. Yeah. What else? Lymphic lesion, yes. Or When you say lytic lesion, it can be a plasmacytoma, right? You can get plasmacytomas, right? Then the plasmacytomas are commonly involved in the head and neck region. Okay, so on an X-ray it might look like a lytic lesion, but it can be a collection of plasma cells. Okay, so this man came with this jaw pain, and when I did X-ray, found this plasmacytoma. And we did when you look at his blood count, you could see that his blood count was very low. He was having a pancytopenia, right? Why do you think he was having pancytopenia? Sorry? Yes, okay. So his all three cell lines are very low. Why do you think? What are the possible causes? So let's say you are in the EQ and you see this patient who's coming to you saying his jaw pain and he's feeling quite tired, and you get his proper history. You do an X-ray to see why he's having pain, and you find this, and you do a full blood count, and you find that his hemoglobin is 7, neutrophils are 0.6, and the platelets are 15. Right? Now, what goes through your mind? What should you be thinking? Now, why is he having these low platelet counts, low blood counts? Sorry? Could be drug induced, yes. So you need to quickly see what drugs he's been on and whether they can actually cause pancytopenia. So could be drug induced, or secondly, could be sepsis. Well, sepsis alone is not going to cause all this, right? He could be having sepsis due to this, but it's unlikely for sepsis itself to cause this much of pancytopenia. It can, of course, yeah, but anything else, more importantly. So drugs, yes. Second, remember we're talking about hematological malignancies, right? Where do hematological malignancies happen? In the bone marrow, right? So this could be disease progression, because you've suddenly found that he has probable plasmacytoma appearing here, and you find that his blood counts are all low. So it could be that the multiple myeloma is now just full of myeloma in his bone marrow, right? Okay, are you with me? Okay, so these are the two important things you need to figure out at that point of time. Yeah, because it would mean your next step of management would be based on this, right? Okay, so then because we did a bone marrow and we found his bone marrow was stuffed with plasma cells, we need to do something about it, right? And we decided to give him what is called salvage chemotherapy, very, very strong chemotherapy, using adriamycin, and you all know what adriamycin is, doxorubicin. Adriamycin, it is a very strong type of chemotherapy which is used in leukemias, right? Then platinum, cyclophosphamide, you all know, etoposide. These are all very myelotoxic elements which we are trying to use to kill off his myeloma, right? Now, to give these very toxic regimens, you have to get him into hospital, and you have to give it through a central line, okay? Because in this particular regimen, you'll have 4 separate infusions running into him for 4 days, continuously for 4 days, right? So he's going to need lots of IV access, including a central line. Okay, so the next thing is we need to get this central line into him. Okay, especially if he has come sort of very collapsed and all that, then you'll have to first get IV access, resuscitate him, give fluid resuscitation, stabilize him, and then think of putting central lines and all that. Or if you can't, in case you always go and put a central line, you put central lines and all that, in the ETU. Okay, so that's another thing. Now, so he's got a central line in. We've got to obviously cross-match his blood and have blood ready. Do an emergency grouping, because he will need platelets. He will need probably blood also. Okay, and we can start him on colony stimulating factors, because even if it's drug induced or even if it is bone marrow failure, if he needs it, we can give it to him, right? The place where you have to be careful is, what is GCSF? What is GCSF, or filgrastim granulocyte colony stimulating factor, right? So this stimulates granulocytic precursors and so on. Okay. Now, if this man had a myeloid malignancy, like an acute myeloid leukemia or a myelodysplastic syndrome with a lot of blasts in it, giving him granulocytic colony-stimulating factors might even fuel progression of the disease, right? But not that we don't do it, but we have to be careful. But someone with a lymphoid malignancy or a myeloma, right, giving him colony-stimulating factors is not a big deal because that's not going to stimulate myeloma cell formation or that. Okay, so if necessary, we can give it to him without much thought, especially if it's drug-induced. He will benefit by giving him colony-stimulating factors, right? So I'm not saying that at this point with this patient we should give it, but there are things which you should go through your mind, right? So unfortunately his blood group was also O negative, and you need to liaise then very quickly with the transfusion colleagues to make sure that they have blood platelets ready for resuscitation if necessary. Okay, right. So now I'll see this one. Okay, so this is what I was talking with you about. When you're assessing this patient, you've got to first of all see his neutropenic, right? First of all, assess to see, I was telling you, whether there's a high risk, medium risk, or a low risk, right? Based on the disease and the chemotherapy regimen that he's been given, right? So this guy, immediately he goes into this high risk category, okay? Because I told you a lot of he's having a lot of myelotoxic substances, and also he's had lots of treatment before this. He's had transplant, so he's not the best candidate. He's had a lot of previous exposure, right? So immediately he will go to this area, and therefore we will give him GCSF anyway. Okay, are you with me? Right? So it depends on, that's what I was just telling you, depending on what the chemotherapy regimen, his general age. If he is an older man, even with a less myelotoxic chemotherapy regimen, we would give him GCSF if he's sort of old and frail and feeble and all that. Okay, are you with me? So that's just a quick assessment we do at that point of time. Right, now again with this chemotherapy regimen, I told you DT-PACE, it knocks out your lymphocytes, it knocks out your white cells, your B cells, T cells, everything, and then you're more susceptible to not only bacterial sepsis but also fungal infections. Okay, you are also susceptible to things like pneumocystis jirovecii, right, or PCP as we used to call it, and therefore he should be on what is the prophylaxis for PCP? Cotrimoxazole, isn't it? So the bad thing about cotrimoxazole is that itself can cause bone marrow suppression. Okay, but sometimes we have to put them on that for the lack of other things, right? So you have in sort of overseas we have a drug called pentamidine, okay, which we can use for PCP prophylaxis, and it can be used as an inhalation as well. So once a month inhalation with with pentamidine also gives some sort of a prevention, protective effect, and doesn't cause this much of marrow suppression. But we use sort of we have used cotrimoxazole, right? So fluconazole had to be given to this patient because of antifungal prophylaxis. We look at fungal a little later. And then due to the high steroids at the low, we're going to give high dose of dexamethasone. These platelets are low, so we need to have some GI protection as well. Okay, so when you see these patients, make sure that you are looking at all these aspects. Okay, while maybe resuscitating and treating him for neutropenic sepsis, you need to see that you have covered all the bases, right? Some of these patients who have a lot of lymphocytotoxic drugs being given, they need to be on acyclovir as well. Okay, and why? What is the main reason why we give acyclovir prophylaxis in some of these patients? For yes, and something else for zoster. Yeah, so zoster reactivation, and you don't want this patient to have a reactivation of zoster, which is going to be hard to manage, right? So acyclovir is used commonly for prevention of reactivation of herpes zoster. Okay, Right. So now he had his chemotherapy and all that went off quite well. Then 6 days after chemotherapy, he presented with a productive cough. He had a temperature of 38.5 with chills. He had gained about a kilogram. His lungs had crackers. Blood pressure was 100 by 65. Hemoglobin 8, neutrophils zero point 0.1, and platelets 12. Okay, so let's say he comes to you like this in your ETU. What are you going to do? So is he having febrile neutropenia now? No? Do you think he has, right? So how do you define febrile neutropenia? What are the sort of accepted definitions of febrile neutropenia? Less neutrophil count less than 1,000 or 500? 500, no? Right. Or 1,500 is it? Severe neutropenia is less than 500, very severe neutropenia is less than 200, right? But for febrile neutropenia, we need to have obviously fever and neutropenia, right? Some of them, sometimes it's referred to as neutropenic fever, right? Various different things. So neutrophil count less than 500 or 0.5 into 10 to the power 9 per liter. What about the fever component? How much of fever do you need to have to be able to sort of do? Right. So this. Okay, so this is, I think, I can't see the list, but I think these were the Sri Lanka College of Microbiologists. The Sri Lanka College of Microbiologists 2016 have a guideline out on neutropenic fever, neutropenic sepsis, right? It's online, so you can go and have a look at it. It will be important for you to see that. So if your neutrophil count is less than 500 or you expect it to decrease, 900 or 800 today. 2 days ago, it was 1,500. Chemotherapy was given last week, right? So you're expecting this to come down to less than 500 in the next couple of, maybe the next, by tomorrow or day after. Again, you have to sort of classify this patient as febrile neutropenia. If you're a single oral temperature of 38.3, more than equal to or more than 38.3 centigrade, okay? Or a temperature of 38, which is sustained over an hour, right? So occasionally you have a patient coming in with a high temperature, but it sort of goes down. Remember, there are lots of things going on in this patient, isn't it? It's not just the fever, but they got chemotherapy, they are having a malignancy, there's cell breakdown. So it may not be purely neutropenic sepsis just because they spike a temperature, right? But you are going to on the side of caution and treat them like that. But this is the definition, okay? The other point I mentioned to you earlier, even if the patient doesn't have fever, but clinically you suspect that the patient has sepsis due to the fact that they are hypotensive, they are cold, clammy, they have this very strong history. all three, the peripheral as well as the three central line lumina around about these times, right? And later on it was found to be a Staph aureus, right? So 19, 21, and 19, peripheral blood culture became positive at 35 hours. Okay, so that's much later on, right? More than 12. That's what I was explaining. Right, then biomarkers, procalcitonin and CRP. Okay, so if you look at the procalcitonin, the sensitivity and specificity appears to be slightly better than with CRP. Okay, and if we have procalcitonin available, we don't have it available in the state sector, isn't it? Only in the private sector. But state sector, you have it. Where at MRI? Can you have it? Right, okay, that's great. I didn't know that. We don't have it here, no? Only in Canada. Right, that's great. So that is probably a little more sensitive and specific than the CRP, but CRP is also very good. But remember, even the CRP can lag behind. So as the patient comes, the CRP cannot be elevated, and then when you do the CRP the next day, the CRP can be high. Okay, it can go up. So it's not, it doesn't correlate immediately with the time. Okay, so you might, the patient comes in, maybe CRP is say 10, 15. You start on antibiotics, and the next day you do the CRP, it can be 100, right? And you're wondering now, you sort of, you're giving antibiotics, but still the CRP is going up. Okay, so it doesn't have that closer correlation to the time, right? Another thing that might help us is this one, the Multinational Association of Supportive Caring Cancer Prognostic Index. Okay, now here if this MASCC score is high, okay, then the chances of mortality can be low. Okay, and if the score is low, then the mortality of this patient can be quite high, right? So this is how the score works. I won't go into details in that because it's going to take a lot of time. Okay, so just have a look at that as well. And these are the again from the Sri Lankan College of Microbiology guidelines 2016 about antibiotics, right? Yeah, I can't. It's not good. Okay, I go check it. Okay. Okay, so what are the recommendations? You can see that in, let's say in our patient that we were talking about, what would you start off with? What would be your preference in terms of antibiotics? Yeah. BD. Oh. If test 4.5 is usually given 8 hours or 6 hours, right? And plus or minus a aminoglycoside. Okay, because it has a synergistic effect, isn't it? And these basically you need to use a broad spectrum antibiotic covering both the gram negatives, positives, and the anaerobes. So you can decide underlying disease, suppression, minor suppression the patient had in terms of chemo. So in this patient, you would probably add a aminoglycoside as well. What about gram positive cover? Not gram positive cover, MRSA cover. In a patient like this who has line infection, you've grown something from the line, you've grown a Staph aureus, you might initially itself start off with either vancomycin, as mentioned here, or an alternative is glycoprotein, right? Which we did in this patient. Okay, we added it right up front because of this other issue. Okay, so should we share stop? Not sharing here. We'll continue sometime later.
So let me know sometime. No? Sorry, no. It will take some time. We started late because there are some technical issues. It's okay. We can maybe do it some other time. Isn't it? No, it's almost 5 minutes. Yeah. Right. So we'll have it another day then. Okay. Right. Thanks. Any burning questions, or we'll leave it for next time?